Hello, everyone. Welcome to the Department of Psychiatry and Behavioral Sciences Grand Rounds. My name is Joe Saramelli, and I oversee Grand Rounds for our department. So today is the second to last Grand Rounds presentation in this series for this academic year. And we've had presentations covering several different domains. And I'd like to encourage participants to fill out the evaluation afterwards. That's been helpful in recent months to understand people's impressions of the presentation. Also, please write in comments or questions into the question box, and I can go through them with our presenter afterwards today. So for today's presentation, Dr. Priya Gopalan from UPMC is presenting. Dr. Gopalan is Associate Professor of Psychiatry and Chief of Psychiatry and Medical Director for the Psychiatry Consultation-Liaison Service across 9 hospitals, which is very notable to me to think about delivering services in that many settings, establishing and maintaining relationships with colleagues across multiple sites. Dr. Gopalan has been active in programmatic development in CL Psychiatry, Perinatal Mental Health, and in telepsychiatry, CL Psychiatry as well, which is the topic of today's presentation. I'll stop sharing my screen there and give Dr. Gopalan a little bit of time to get slides shared, and I'll hand it over to Dr. Gopalan.
Thank you. Let me get this going here. Of course, the second I clicked on it, it disappeared on me. So give me 1 second to get this back up. Can you see my screen now?
Yes, that's
excellent.
good.
All right. And I'm going to swap the views here. Excellent. Did that work out okay?
That's good.
Okay. So this is not actually my title slide. I'm going to start here. First of all, thank you all for having me here. I'm really excited to be talking to you all, and just wanted to sort of start out by saying that I have a very long title for this talk, but what it really boils down to is I'm going to be talking a lot about our institution's experience with telepsychiatry and consultation liaison psychiatry in particular, and really how we have explored this over the years as a way to really capture and engage patients patients who really don't have great access to care. This has been a journey of really multiple hospitals, like Dr. Saramelli mentioned. I work for Western Psychiatric Hospital, but my sort of clinical home has been at McGee Women's Hospital, and that's where my career kind of started. And I wanted to just take a second to sort of acknowledge that. I also want to start us off with kind of a personal story. So I joined our consultation liaison psychiatry team back in 2011 after training. In 2014, I was appointed medical director of the service for a pretty large hospital system already. I had 6, at that point it was 6 hospitals that were under that purview. I was the youngest person on the service at the time of our faculty, and I had spent the first year or 2 working actually part-time. So I was sort of given the mantle at a pretty early stage in my career. And then of course the second I took over, the next thing that was sort of said to me is, oh, by the way, you are responsible now for adding a telepsychiatry arm to the service. We've been talking to this hospital, have at it, go at it. Of course, I'm very fortunate to work in a large healthcare system, so I had lots of supports, but UPMC Horizon is the hospital that we were told to add on at that stage in 2014. And just to, in case you're not familiar with the geography of Western Pennsylvania, which I certainly wasn't until I came here for residency, this is sort of the map of where Horizon sits. So just to orient you, the bottom right is Pittsburgh and the top left is Cleveland. So UPMC Horizon sits somewhere kind of in the middle there, and is pretty far away from both major cities. So we're talking about an area that's pretty rural overall. So it got me thinking very early on about access to care. And throughout this presentation, I'm going to be using some case examples of just some cases that we've encountered through our telepsychiatry experience through the consult service. These are cases that other people sort of gave to me to use for this talk. And I'm not, what I'm using, I'm not trying to imply that, this is universal to rural healthcare by any means, but I just wanted to sort of preface by saying that I'm hoping to sort of bring some of this home for those of you who are clinicians in this meeting. So I'm going to actually start us off with a case. This was actually fairly recent. We had an 11-year-old, which in and of itself is a little bit unusual. Our service doesn't really see a ton of children, but we had an 11-year-old male who was admitted to one of our rural hospital sites after an overdose on multiple medications. On admission, his vital signs were abnormal. He had significant tachycardia, and he told the admitting physician pretty clearly at the time that this was an intentional overdose. The initial H&P was notable for patient being confused, voicing some visual hallucinations and delusions. But the line that really stood out to the consulting psychiatrist was the one that I've got bolded here. So after reading the H&P and after speaking to the patient and mother, I couldn't really find a sentinel event leading to this drastic action. And I wonder if acute psychotic episode is on the differential. And when the consult reason came through, it came through as overdose, schizophrenia. So our attending CL psychiatrist, and we were quite fortunate that we had a child and adolescent psychiatrist on service with us on that particular day, after sort of picking up her jaw off the floor, went and saw the patient via telepsychiatry consultation and made the diagnosis of delirium due to a toxidrome, advised supportive management for that. And the patient's psychotic symptoms did eventually resolve over time, and he was transferred to a child and adolescent psychiatry unit for further care. So again, I'm not meaning to imply that this type of care doesn't happen in other places, but this is just one evidence of some of the cases that we encounter through our telepsychiatry service. So, speaking about access to care, we all know that there is a physician shortage in the United States. In 2019, the AAMC conducted a study and they predicted a shortage of 46,900, somewhere between 46,900 and 121,000 physicians by 2032. And they predicted that this would be in both primary care and specialty care. And this is pretty notable. And the reason it's notable is because the AAMC had actually been working pretty hard over the years to increase medical student enrollment over time. And they had a target of about 30%. They wanted to increase the medical school positions by 30% between the early 2000s until 2019. And they came pretty close to reaching that target. They got to 29.2%. So I'm going to ask you all to take a second. You don't have to, write this down or put it in the chat or anything like that, but I just wanted you to take a second to consider and think about what the issue is then. So if we have this increase in enrollment, certainly we could continue to increase medical student enrollment if needed. Why is there a shortage, and what is causing this, and what kind of factors might be coming into place? I'm going to let you all think about that for just about 30 seconds before we answer it. And of course, the answer is really not that simple and not that straightforward, but a big factor in our physician shortage is actually the fact that we really don't have enough residency positions to keep up with the physician demand. So, while we have a lot of graduating medical students, and just to orient you to this graph, you'll see on the x-axis here, years, and the y-axis is the number of applicants and positions. So the blue line on here, sort of blue-green line, is the total number of applicants, and you can see that it's gone up over time. So this is the number of graduating medical students who are applying into the residency match, and the purple line that you see in the middle there is the number of residency positions, or at least intern first-year residency positions overall. So, a slight increase over time, but certainly not enough to match that increase in medical school enrollment that's happened over time. So we really are talking about a pretty big mismatch that's likely to continue to be mismatched over time. So I'm going to ask you all this question. So why are there so few physicians graduating from residency training? So again, take a second, read through these answer choices and think about what the answer might be. Is it that the American Medical Association is lobbying to keep slots limited, to keep salaries up? Is it that the state medical societies are actually, the ones to blame? They're restricting residency slots to keep costs down? Is it that there are not enough medical schools in the United States, even with this? Or is it that the federal government has a cap on the number of residency positions? So think about what the answer to that is before I answer it. And if you answered D, then you're correct. And in reality, there are probably not enough medical schools still. But the real sort of issue with a lot of this is that the federal government does cap the number of residency positions that they will fund and approve. So, this is just something to think about. With this background, there is also another trend that has been happening in healthcare that I think is really relevant to this discussion. And that is the trend towards consolidated health systems. And I know you all have experienced this yourself in Washington, and certainly we have here in Pennsylvania. The top map is consolidated health systems. And when we talk about consolidation, we're talking about both horizontal consolidation, so hospitals buying hospitals, and also vertical, so hospitals buying practices. And we've seen certainly a very large increase in consolidated health systems over the last couple of decades. So, it's important to know from an access standpoint, it's important to know just from a practical sort of execution of care standpoint. And the hospital system I work for is really no exception to this. So the UPMC health system, for those of you who are not familiar, is a massive corporate healthcare system. It is a payer-provider healthcare system, and it's an academic healthcare system. So this is just a fraction of the hospitals. The UPMC umbrella has over 44, I think, hospitals and counting at this stage. These are the Pennsylvania hospitals, and you can see that there are quite a number of them already that range from the very western border and all the way to almost, the eastern part of the state. But we also have locations in New York. We have locations in Western Maryland, and we actually have international locations in Ireland and Italy and China. UPMC has a very large kind of footprint in this region. Thankfully, I am not responsible for all 44 hospitals, the consult services in all 44 hospitals within this system. I'm very grateful for that. But I do have a fair number that my team actually sits in. So the ones on the left part of your screen are our in-person sites. Most of them are in the Pittsburgh area, and the three on the right side are our 3 hospitals that we've added on through telepsychiatry in the last 6 years or so. Of those, we have the longest standing relationship with Horizon, and we added Jameson and Northwest in pretty quick succession in 2017. And for those of you, keeping count, this is not 9, this is 10 that's listed on here. And the reason for that is because Select Subspecialty is actually our long-term acute care unit that's sort of embedded within Presby. It's sort of it's a hospital within a hospital, but really it's an LTAC. So I put it on the list just for being comprehensive, but it's not really a hospital in and of itself. Our experience has also been really interesting. 2 of the telepsychiatry hospitals do have labor and delivery units. Those are Horizon and Northwest. And we've kind of discovered over time that even though we've established relationships with hospitals, that sometimes the labor and delivery units kind of sit alone. So our sort of trajectory with those particular clinical services is that we first established in the hospital, and then the OB consultation actually came a few years later, and oftentimes only after we did a lot of outreach and sort of education and kind of said, hey, we're here, we really want to help you, we want to take care of your patients. Just one more map, I promise, and then we'll move on to sort of more interesting topics. But just to give you a little more orientation here, this is the western half of the state, and Allegheny County is where Pittsburgh sits. So all of our in-person sites are on that blow up, that sort of yellow blow up image over there. So almost all of them are kind of in that little bucket there. And our 3 telepsych sites are where those 4 stars are, and that's because the 2 stars that are in Mercer County are 2 campuses of the same hospital. But as you can tell from this map, they're actually fairly far away from each other. They're about a 30 to 40 minute drive from one campus to another. So that presents its own kind of unique challenges. But the lay of the land is this: most of our hospitals sit kind of more towards the Ohio border than they do farther east. And it's interesting actually, because in my mind, consultation liaison psychiatrists are a fairly flexible group. We have to deal with a lot of different hospital systems. We have to work with a lot of personalities, and we have to work with a lot of different types of patients, variety of patients. You never know what you're going to get when people walk in. But when I introduced the idea of telepsychiatry to some of the attendings on my team, I found that there was a fair amount of anxiety around sort of just taking this on and going and running with it, and anxiety from people who are very experienced and people who, you know, probably would be very adept at executing telepsychiatry consultation. I found that it took a little bit of convincing. And, you know, you remember we started this in 2014, so we didn't have access to the same kind of data that really showed effectiveness and comparative sort of effectiveness. There were a few at the time. There still aren't as many as I think I would love to see, but, you know, COVID has given us a little bit more to work with, which is great. And I suspect that that's going to continue to grow and evolve over the next few years as telehealth in general becomes more of the norm as opposed to the exception. But I just wanted to highlight a couple of key studies in this area in my mind that I came across when I was putting this together. One is a pretty recent systematic review looking at the use of telepsychiatry in depression as a whole. And I kind of focused on this because depression is kind of our bread and butter in psychiatry. So this particular systematic review looked at 14 studies. They looked at adults, any clinical setting, and any healthcare profession. So really kind of looking at this in as general of a way as possible. And they said, you know, to be included in this review, they had to have, you know, at least one kind of outcome related to patient satisfaction, efficacy, or cost effectiveness. And when they kind of pulled it all together, they said, and they found that, you know, satisfaction was pretty much equivalent, whether it was face-to-face or video, and even tilted maybe slightly towards televideo being more accepted by patients and resulting in higher patient satisfaction. Both the televideo groups and the control groups found relief from depression, which is a good thing. And any increased costs that kind of came up with televideo in terms of infrastructural costs eventually ended up kind of rounding out, and because eventually telehealth was the more cost-effective modality of care, and they speculated that that was due to reduced travel expenses based on their review. Again, you know, that's sort of general telepsychiatry to depression. If you sort of jump in and look at more specific settings, and maybe settings that are not just sort of traditional outpatient care, there are studies that have looked at this area as well. This is one that I saw that was, you know, very, very recent. So it came out earlier this year and looked at telepsychiatry in ED settings, which I thought was, you know, not exactly, you know, identical to what we do on the consult service, but probably there are some things that could be adapted and applied certainly over there. So this particular study looked at a very, very large national ED inventory database, and they pulled out the emergency departments that were in New York State, and they were looking at two outcomes in particular. So one was the use of observation services, and one was ED visit disposition, basically. And they said, is there a difference when there is telepsychiatry being used versus not? So just to give you a sense of what these numbers look like, they were looking at 712,000 visits in EDs without telepsychiatry, comparing it to 101,000 visits in EDs with telepsychiatry. So, you know, we're talking pretty large numbers. They found that telepsychiatry had lower odds ratios for use of the OBS services like sitter services and so on, compared to visits in EDs without telepsychiatry services, and that the dispositions were pretty comparable between the groups. So, you know, this is something I think that was helpful for me to see personally. And I think what you all are probably experiencing on a very practical level is bearing out in the data as well in terms of show rate. So when looking at outpatient community mental health samples, this particular study looked at COVID-19, sort of the pandemic, and what happened with show rates and attendance for telepsychiatry visits just within the pandemic itself, but also compared to pre-pandemic times, and found that using telepsychiatry was associated almost a 7-fold increase in the odds of actually completing the visit compared to in-person. This is during the pandemic. When they compared it to pre-pandemic time, they found a 3-fold increase in terms of the odds of completing the visit when using telemedicine compared to in-person. So, you know, this is certainly something that we all need to be thinking about in terms of patient engagement. This is, of course, focused on outpatient samples. And now I want to take a very short digression for what I am calling for myself, or to myself, my fangirl moment. So I have always been very much in awe of your institution and the work that you all have done in this area. I've learned a lot from just reading the studies that you have done. So I wanted to take just a moment to really appreciate the work that you all are doing in Washington, and just the really innovative sort of things that you're looking at. We need more studies that are looking at really rigorous kind of quantifiable things. And I'm not a researcher, so I'm always in awe of people who are. I very much identify as a clinician educator and as a clinician administrator. So I just wanted to take a second and do my fangirl interlude. So I wanted to say, appreciate the really great work that's being done in telehealth, just globally, but especially in the areas of integrated care and collaborative care where you are. Really appreciate looking at relative effectiveness. We just don't have enough studies that compare effectiveness of telehealth treatment. So I know you all have done incredible work in this area. Really great work and publications in CL psychiatry. So, I wanted to sort of highlight that. This is really incredible and great for me to read and appreciate. And in women's mental health, which is my other area of passion, which we will talk about in a little more detail. But you've done, not only really great, rigorous research in these areas, but have also really explored innovative models of care, which I think is really important when we talk about access and when we talk about patient engagement. So, thinking really outside of the box of technology and how to use it in a way that's, accessible to patients, but also just how to do it across a wide array of settings and samples, and especially when there's geography at play that often serves as a barrier. So that's my fangirl interlude for you all. But I also use that to sort of pivot to the topic of really thinking about outcomes and talking a little bit about the work that we do, which Dr. Sarah wanted me to sort of cover a little bit. So, when thinking about telepsychiatry and outcomes, it is really, a really kind of emerging field, I would say. So it's something that I think bears a little bit of discussion. So I wanted to start us off, though, before we jump into this topic, with another case. So we have a 59-year-old female who was admitted to the hospital for urinary tract infection and electrolyte abnormalities. So our team was consulted for bereavement. That was sort of in the reason for consult due to a recent loss of a family member and appearing to be more withdrawn. Our attending psychiatrist went into the room, through the video, saw the patient staring, confused, unresponsive, and stepped out to recommend really a altered mental status workup. She was quite alarmed. And it turned out she had a pretty good reason to be alarmed, and the patient was actually in status epilepticus, meaning she was having a prolonged seizure, and was transferred to a tertiary care hospital. This was sort of early in our telepsychiatry days. And honestly, it was experiences like these that actually helped to sort of convince, my own team that this was a valuable sort of modality of care. Early days of this, we really wanted to see, what kind of outcomes we could sort of look at. Is there any utility to what we're doing? And again, through the lens very much of someone who does administrative work, some quality improvement work, but not really like rigorous sort of research. So we took on a project pretty early in our involvement with Horizon to sort of look at the patients who we were seeing through telepsychiatry consultation and said, can we look at healthcare utilization parameters? And, can we do that in a very circumscribed way, looking at the time periods before and after consultation? And then is there any possibility of comparing the patients we're seeing through telepsychiatry to patients that we're seeing in person at hospitals that were similarly sized? So we took a time window. Again, these were sort of early on in our Horizon experience, and pulled out the consults that we saw. And out of those, most of those were, we pulled out the inpatient ones in particular for the analysis. And we picked a couple of hospitals that were pretty comparably sized, and that we thought would be kind of an appropriate comparison point compared to like our tertiary care hospital here, which really has a very different flavor in terms of patient care. And we did a comparative sort of study. So what we did is we looked at data points up to 90 days before and after, and we looked at outcomes that were very specific to healthcare utilization. So ED visits, inpatient visits, and we have a quality improvement center here at UPMC, so they did some matching across multiple variables, including some sort of psychosocial ones, median income, and so on. And they did the comparisons for us. So the bottom line on this, and I could go into more detail if you'd like me to, but But the bottom line of it is when we looked at, this is just the telepsych consults compared to themselves. So like the time period before and after the admission for consultation, we found a decrease in inpatient utilization for this at the 7-day mark post-discharge compared to the 7 days pre-admission. And this was also true for our ED visits. They also had decreases. Inpatient utilization was only at 7 days, but our ED visits were reduced at all time points, 7, 30, 60, and 90, and they were all statistically significant. When we compared our telepsychiatry site to our in-person sites, and this is where I think I was sort of the most surprised. I sort of always assumed that we would do better in our inpatient services. Telepsychiatry actually had a reduced odds of future ED visits at all time points compared to in-person, and lower odds of inpatient visits too, but that part wasn't actually statistically significant. So, you know, we actually had, in some ways, telepsych outperforming, although of course, you know, this is a small sample and a lot of other things to sort of consider, but we started to wonder whether the impact of telepsychiatry in under-resourced areas might actually be greater just by nature of, you know, giving care to an area with limited access to care. So it got us sort of thinking a little bit more about perinatal psychiatry in that world. So I'm going to shift gears and talk a little bit about women's mental health and our experiences there. So just to use a case to serve as our anchor, we have a 24-year-old female G2P2 with a history of anemia and depression who's admitted to UPMC Northwest, which is one of the 2 sites that have a labor and delivery unit at approximately 37 weeks gestation. And when we saw her, she was post-op day number 1 after a C-section where she had no complications. We were called in because she had a pretty significant depression history. She'd had 3 prior psychiatric admissions, once as a child, once during her last pregnancy, and then again actually during this one for bad depression, panic attacks, and flashbacks is what she had told us. The line that really stood out for me as I was reviewing this case, this is not someone I saw personally, but reviewed the chart kind of after, was this, and you know, patient sees such and such person who does psychiatry in such and such city, who told her that escitalopram is harmful for babies, and switched her to sertraline for depression and anxiety, with the notable point being here that escitalopram had actually kept her pretty stable up until that point between her pregnancies. So they were switching for reasons that were not really fully evidence-based, and certainly not in line with kind of the shifting paradigms of perinatal mental health. So just to take a big step back and talk about perinatal mental health, just to, you know, as an area that is an area of passion for me. I'm sure everyone is fully aware, and especially with all the great work you do in this area, with Dr. Bhatt and others in your group. You know, pregnancy is a complicated time. Our patients often have to deal with all kinds of different stressors, mental health stressors, depression and anxiety. Oftentimes there's a trauma overlay, substance use overlay, and this can, you know, weave a very complicated type of clinical picture for those of us who care for patients who are pregnant and postpartum. We know that untreated depression and anxiety actually carries with it significant risk during the peripartum period. So anything from poor prenatal care to, you know, obstetrical complications to, you know, things like increased rates of smoking and substance use, higher rates of suicide, increased rates of obesity, to complications with the baby like decreased birth weight, preterm delivery, and of course, you know, depressed mom going into that postpartum period oftentimes will struggle with that sort of bonding and attachment process that happens in those critical periods right after delivery. This is important for a lot of reasons. It's important for mom, it's important for baby, but we also know that stress during pregnancy can actually have some pretty complex kind of intergenerational effects, and can affect, you know, just about everything from neonatal, you know, brain development to the sort of social and developmental interplays that happen postpartum. So, you know, we sort of thought about the overall context of mom and baby and that dyad and the effects that it could have in terms of treating moms. And then of course, around the same time, you know, we start to hear quite a lot more about maternal mortality and morbidity. And again, I know you have people who serve on these committees for your state where you are. So I'm not going to belabor this too much. I'm sure you've heard it all before, but this is the CDC report from 9 MMRCs. This was published a couple of years ago. And, if you kind of look at this, mental health conditions is actually on this list of pregnancy-related deaths, which is, I think, really, really interesting, given that pregnancy-related deaths has a very, very concrete definition that says that the death really has to be due to something like directly linkable from to the loss, right? So that things like preeclampsia and that kind of thing, there's sort of a physiological link. We actually have not gotten a published sort of systematic report for Pennsylvania on pregnancy-related deaths, but we did have a very recent published report on pregnancy-associated deaths in Pennsylvania. And what this means is that there's a link between the condition and the maternal death, but maybe not one where you could directly sort of link it. But this was published very recently, just at the end of last year. And I want you to think about, and maybe this is based on your own experiences, but what would you consider, what would you hypothesize the leading causes of pregnancy-associated deaths to be in Pennsylvania? And again, I imagine that it is very similar in Washington State. So just take a second to think about what that could be before I sort of walk you through what all came out of this report. So, the way this particular report went through the data, they had to sort of go back retrospectively. This wasn't designed to kind of pull out this data. So, take it with a grain of salt. Certainly the authors make that kind of preface, but the leading causes of pregnancy-associated deaths in Pennsylvania, to me, were pretty remarkable. So what I really want to point out to you is that the number one cause is accidental poisoning. So we're in the Rust Belt here, so a lot of this is opioid overdoses that occur in this region. We are in one of the hotbeds of the opioid epidemic, but it is certainly something that is well within our purview in terms of mental health and being able to, possibly do something about it and intervene. Intentional self-harm is on this list. Again, definitely something that falls under our purview. And assault, so trauma, once again, is another one that's on this list as being leading causes of pregnancy-associated deaths in Pennsylvania. So, this is something that I think is really notable and important and very consistent with the data that's coming out of other states. But the Pennsylvania report also made sure to kind of mention rural versus urban as a part of this, and found that pregnancy-associated deaths were pretty evenly distributed, in both rural and urban counties across the state rather. So, this I think was also interesting to us, and also gave us more of sort of a reason to more actively pursue some of the obstetrical partnerships that we have over time. So of course, my sort of reaction to a lot of this was to go to the primary literature and sort of see, do we have any data on telepsychiatry used in the peripartum period? Are there studies that tell us that it's okay to do this and that the outcomes are pretty good? Or is there anything unique about pregnancy and postpartum where we shouldn't necessarily be pursuing this as aggressively? And it turns out that, there are very sort of limited data on this. This is just a couple that I found that I put up here, and I'll walk you through this. But the data that we have suggests that it's probably equivocal to in-person care. So this came out in the SHORE study came out in 2020. They looked at telepsychiatry and integrated care programs, and I know you all have published data on this as well, and found, again, consistent with some of the other studies that are out there, that pretty high rates of treatment engagement were possible with telepsychiatry, which is great. They made an attempt as best as they could, given that this was sort of a real-world sample, to look at ED utilization rates and breastfeeding rates, just to look at those types of outcomes. And found that there were both low ED utilization and high breastfeeding rates in depressed moms who were able to be engaged in telepsychiatry services in this integrated care setting. And so at this medical psychiatric interface. This other study was a meta-analysis of 8 other studies in peripartum mental health, looking at telepsychiatry, and found improved depression scores with outpatient telepsychiatry. So again, this is just a kind of a sampling of what's out there, but things that are pretty promising in terms of this modality of care in this particular patient population. In 2019, we decided that, with a hospital that had a labor and delivery unit that really wasn't using us or calling us all that often, if at all, that we were actually going to be a little bit more proactive about this and reach out to them. So in 2019, 2 of the attendings on my team, me and Dr. Shania, who some of you may know, reached out to the OB services over at Horizon Hospital and said, hey, just wanted you to be aware that we're here. they were actually not aware that our service actually existed, even though we'd been there since 2014. And we have a clinician who's on the ground at Horizon Hospital who said, not only are we here, but I'm willing to round with you guys. Like, I'll round with your nursing team. Let's try to see what we can do in terms of optimizing care to our pregnant, or really our postpartum patients on that particular unit. So we started to generate consults, particularly through this rounding that our clinician was doing on the ground. And over time, you know, as awareness sort of was raised that we existed, they also started consulting us independently as well, which was really nice to see. So we undertook our sort of second project in this area and said, all right, well, now that we've been doing this for a while, after about a year, we wanted to really see what kind of care we were providing, because the other question too is, just because we can provide care, is it like worthwhile care, or are we just sort of doing it to do it? So we pulled, 1 year sample of consults that we saw to the labor and delivery unit specifically, and we pulled a bunch of different data parameters to do a descriptive kind of analysis. So we looked at demographic data, we looked at NICU, we looked at all kinds of different parameters. They're all listed here, so I'm not going to read through them. We have our consult notes are set up so we can actually pull things like reason for consultation and recommendations in a very automated way. So we were able to do that. And then our health system, our EMR, we're again very fortunate that we can actually look at pharmacy fill records, whether it's within the UPMC system or not. Like, we have a button on our EMR that lets us look at that. So when that data was available, then we also took a look at post-discharge pharmacy fills, because you can start a med, but that doesn't mean that people are continuing them, right? So what we found was that we had done a total of 116 consults, but that 85 of them were done via telepsychiatry and actually saw a physician. And the others, the reason that number is not matching up is that the others did not actually consent to a telehealth evaluation or were discharged. And actually, this is a very kind of unique thing to this particular hospital. That Mercer County is just one that is very Mercer County focused, and sometimes the patients that we see there just don't want to see a Pittsburgh doctor. So we kind of have to work with what we have there. So we looked at the 85 consults in 2019 that were conducted via telepsychiatry, saw a physician. The demographics are listed here on this slide, and we found a pretty high rate of past or current comorbid substance use disorder. We didn't have an easy way of sort of categorizing whether it was past or current, short of reading through a lot of individual charts. But it's a pretty good number that had a substance use disorder diagnosis in the chart, which I think was one of our sort of notable takeaways from this exercise. This is how our notes are set up in terms of reason for consultation. We're allowed to select more than one, which is why this doesn't add up to exactly 85 reasons for consults. But you can see that what we're getting consulted on are really kind of bread and butter psychiatry, right? So things like depression and anxiety, medication management, and substance use and withdrawal. We actually also have a section in our note that tells us what kind of interventions we're doing with the patients. So we did pull some of that too, because again, if it was very simple and straightforward and we weren't doing a whole lot, then there's not a whole lot of value added. But it turns out that we're actually doing quite a wide array of different interventions with patients that ranged from things like providing education on medications and on their condition, sort of preventive counseling, I guess, or anticipatory counseling on peripartum or postpartum mood and anxiety disorders, bedside therapeutic interventions, reaching out to family, that kind of thing, when appropriate. So, we were pretty satisfied with that. And then we went through and we looked at the med interventions. We pulled out those particular consults and went through manually actually for these to see what kinds of things we were doing with medications, because, the way we have it in our note is pretty generic, and found that we were, starting medicines about a third of the time, 32 cases, 37% of the time, or restarting medicines a few times. So we drilled down on just those particular consults to see if we could get data on how long people were filling prescriptions after discharge. So we had data available on 32 of those 35 cases where we started or restarted, and found that people actually were filling these medicines for an average of just shy of 6 months post-discharge. So, this was a little bit reassuring to me, because although we can't this is inference, obviously. This also meant that I was sort of hopeful that this meant that people weren't just sort of starting their med, going home, and then just saying forget it. So I think that was something that was notable to me and kind of stood out. This is the part that I think is also really, really important. So we categorized follow-up recommendations as well. We did this manually also, but we looked to see how often people were being referred to different services. And about half the time, 47 cases, we actually made a referral for them. Our clinician on the ground made the referral for them, kind of handed it to them. The local mental health agency is not through UPMC, so we were not able to see if they were able to actually follow through and go to their appointment, but we were at least able to have an appointment in hand as they left. And another 10% of the time where I've sort of listed resources provided means we sort of gave them a list of local therapists and things because they asked for it. And really in that area, it's like one big community mental health agency. So most of the time that's where we're referring. So we were doing some follow-up kind of recommendations and connection to care as well, at least to the best of our ability. So, to me, this really sort of convinced me that pregnancy, being sort of traditionally thought of in recent years as a window of opportunity for care, that this really telepsychiatry allowed us to do this and to do this in a very kind of unique and different way. So, the American College of Obstetricians and Gynecologists do have very specific kind of recommendations for some of this. So, looking at their recommendations for screening for perinatal depression, they're recommending screening patients at least once during the perinatal period and completing a full assessment of mood and emotional well-being at the postpartum visit. So, national organizations are saying, this is important. This is sort of a big deal. But then we really kind of got to thinking, well, what about prevention? And I want you to take a second, put it in the chat or write it down, think about, what kind of programs you all have seen and really thought about and then talked about, or what would you like to see that really thinks about preventive care in mental health? Because this is, I think, an area that we all should be thinking about, but is a lot harder to sort of execute. And putting this against the backdrop of, January 2019, I believe, the U.S. Preventative Services Task Force issued a recommendation statement related to prevention of perinatal depression. And to me, this is sort of a game changer. This is something that is not necessarily the way we have viewed the field or talked about things within our field. And the way that they published this report is that they did a review of 50 good or fair quality studies. They pulled out the 20 that were related to counseling services, and they looked at the time of the counseling intervention. So, median amount of time was 8 weeks with 12 hours of contact time. So, this isn't like long-term psychodynamic care or anything like that, at least in the studies that they pulled. We're talking about relatively brief interventions. And they gave a recommendation to provide or refer persons at increased risk of perinatal depression to counseling services. And they gave it a grade B rating. So for those of you who don't have the rating system of the U.S. Preventative Services Task Force memorized, what that means is that they are recommending the service and that there's a high certainty that the net benefit is moderate, or there's a moderate certainty that the net benefit is moderate to substantial. So it's actually a fairly high recommendation. It's a fairly high rating. And they've included some of the risk factors in here. You can sort of see that underneath there, but I also sort of pulled out some of the known risk factors of perinatal depression and postpartum depression. Some of these are very intuitive, things like maternal anxiety or depression during pregnancy, anxiety during pregnancy. These are things that we sort of probably can imagine would raise your risk of peripartum depression. But there are things like, NICU admission that really significantly raises your risk of postpartum depression. Life stressors, I thought some of the social determinant ones were really pretty interesting. So low levels of social supports, stressful life events, that kind of thing are pretty important and are significant kind of risk factors for peripartum depression. So, the last sort of thing and our last kind of undertaking in this area, it revolves around some of this risk factors, prevention of care. We partnered with UPMC Northwest in 2017, like I said before. Northwest is there, where that red mark is through Google Maps here compared to Pittsburgh. It's right by the Allegheny National Forest, but it's a good, 2.5, maybe 3-hour drive from the city. But we were really fortunate that they have a really wonderful OB team that has kind of taken the mantle up for peripartum mental health and agreed to do a screening process and a screening algorithm for us that really involves risk factors for peripartum depression and not just screening using an EPDS or something along those lines. And these are the criteria that we've included within our screening. So a year ago, it's like May of 2020 is when we started this screening initiative, of course, right at the height of COVID. But we used kind of arbitrarily, to be quite honest, a set of risk factors that we thought were pretty important for predicting postpartum depression and anxiety. And we said if you had one of the starred criteria, automatically offer a consult. And if you had 2 of any of the ones on the bottom half of this list, to offer a consult, and they did like a PHQ too, so we include that as part of it as well. Again, we didn't really go at this from a researcher sort of lens. We picked criteria that made sense to us as clinicians, but they were on board with having the OB nurses screen everybody. We offered them some scripting along this to kind of normalize the process. So we said, we offer consults. We know 1 in 7 suffer from postpartum depression and 1 in 10 for anxiety. Would you like us to speak to our colleagues? And in the first year that we've done this, out of the 574 deliveries, we were able to screen a good number of them, 557. 55% came up as being at risk based on the criteria that we chose. Out of those, little over half actually declined consultation even when it was offered. 110 accepted the consultation. So overall, we ended up seeing 19% of the total number of deliveries seen at that particular hospital. And out of the ones that were designated high risk, we saw about 36%. And most of these, like I would say the vast majority of these were done by a perinatal focused psychiatrist who works for me on the consult service, either me or one of my 2 colleagues who are interested in this area. Compared to 2019, this is like a huge difference because there were none. We had not gone to that unit at all in 2019. So what we are doing now as our sort of next initiative is to really drill down into these numbers a little bit. And again, our quality center is helping us with this. We're looking at the people who are screening negative versus the ones who we're calling high risk. And then out of those high risk patients, stratifying them and sort of dividing them and looking at the ones who accepted versus declined. We have very preliminary data on this because our quality improvement people were kind enough to look at this through sort of the COVID pandemic. But they told us that we're on the right track, that the people not at risk had similar EPDS scores, and that was significantly less than the ones who we were calling at risk, whether they declined the consultation or not. They also looked at sort of percentages, and I'm going to sort of go through this quickly because it's a lot of numbers, but the real sort of essence of it is whether they had a high EPDS score or a low EPDS score, they were kind of accepting and declining consults at the same rates. And this was important for us because, if the people who were declining had much higher EPDS scores, then we'd be worried about, well, like, are they declining because they're depressed? How are we going to capture them from a safety standpoint? Should we be checking in more, that kind of thing? Our quality center is doing some preliminary analyses on our algorithm. They're using those postpartum EPDS scores. They're saying we have a sensitivity of 88%, which to me is not bad given that we didn't go at this, with the plan of designing a rigorous, high sensitivity screener, and that there were really no big differences between the groups other than the payers. I'm going to sort of skip over this. The not at risk group had a higher rate of commercial payers. The one sort of area that jumped out as being statistically significant in terms of differences is the at-risk groups, both consulted and declined, had higher rates of anxiety disorders, depressive disorders, and other mental disorders by ICD coding than the not at-risk group, which again tells us that we're on the right track. So we're thinking now about future directions, whether we really want to drill down on, should we be modifying these criteria or should we not worry about that so much as 89%? And I'd love to hear audience thoughts on this. Should we be doing that or should we be thinking about how to automate screens? Because I will tell you, we've had at least 2 other hospitals now come to us and say, we heard what you're doing at these sites. Like, how do we do this? Can you help us with this? Or should we sort of keep going with what we're doing and do something else altogether? These are the amazing people that I've worked with on all of these initiatives. So I just wanted to take a moment to acknowledge them and to reiterate, especially through our national organization in CL Psychiatry, that telepsychiatry is sort of here to stay. This is a task force report that was published this year that I was very privileged to be a part of. And part of the focus of this report was to talk about telepsychiatry and the importance of it and the need for more research. So with that, I'm going to leave the last 10 minutes for questions, maybe 9 minutes at this point for questions or comments. I'm going to stop sharing. And I'll leave this up for a second and then I'll stop sharing.
That sounds great. Well, thank you, Dr. Gopalan. Very interesting. Summarizing different parts of the literature, talking about strategies in several different clinical services. I think as maybe as participants write in a question or two, I'm wondering about the high proportion of people who were seen. I think that's really notable. I can't think of example services where 19% of a patient population is seen by a psychiatry service.
Yeah.
In hospital settings, especially 8.5%, both of which were compared to almost zero or maybe zero in the preceding year.
For Northwest, it was actually zero.
Yeah.
It's interesting, right? And my worry initially when I saw some of those numbers is that, are we just overdoing it, right? Like, are we kind of forcing people to talk to us? But when we looked at those postpartum EPDS scores, I don't actually think that we necessarily are. Certainly some might be kind of overkill consults, but that wasn't what has sort of come out of not just our literature, but also just our experience with it. But yeah, I think it's one of those things, like when you start to look for something, I think it kind of comes up more, right? And I think, the proactive kind of consult models that are coming up all over the country sort of show us this too, right? That if you go at things in a more proactive way, that those percentages do tend to go up a little bit.
Yeah. Interesting. And what has that had not a reverse impact, but has that influenced your on-site services in some way?
It has. So it's interesting. The only other on-site hospital that we have that has a labor and delivery unit is our tertiary care center. So just to give you, and I didn't go into a lot of these details, but just because in the interest of time, but the reason we're able to do this at this hospital is that the volume of screening is about 2,000 a year, and Horizon is probably less than that. It's probably like 1,500, maybe even less at these rural labor and delivery units. At our tertiary care hospital site, it's close to 10,000 consults a year. So if we tried to do this here, I think it would be really difficult. And add to that the tertiary care hospital also has a lot of research programs going on. So patients are constantly being bombarded by, like, do you want to participate in this research study or that? I mean, not bombarded, that's probably not the best use of the term, but they have a lot of people coming in and out of their rooms compared to some of these rural sites, I think. So, I've had administrators here tell me, like, Northwest is like your little incubator. And I was like, well, yeah, kind of, because it's self-contained. You have a group that really does want to work with us and has partnered with us and sees this as a joint initiative, but also a delivery volume that's conducive to this kind of work. So.
And what helped to overcome the initial worry, anxiety of faculty doing this work? Was it just
I'd be lying if I said that everyone was completely 100% pro telepsych right now. I think as people did it more, they started to realize that there was real scope for influencing healthcare in a more kind of large scale system type of way. For one, I mean, this is sort of, given the turnover in a lot of these rural sites, I think sometimes we end up being a lot of the continuity for the hospital system, which is sort of an interesting side effect of our involvement. And I think that has helped. Sometimes we end up carrying on more of the burden of the primary team in some ways, because we are thinking on a very kind of larger sort of holistic kind of way, I think, than sometimes people are able to at these rural sites. So I think that has helped a lot. But I can't say that everyone is 100% universally on board with tele, but I think we've done some things on our service to help with the workflows that have made that better too. We're now trying to keep all of the telepsychiatry with one person, so they have some time to work from home and you know, have a little bit more flexibility in their schedule, that kind of thing. So that has also helped. But, you know, you do it long enough, you get comfortable with it, you know.
And then checking for, I don't see any chat questions coming. I guess another question do you have other services in mind that might make sense where there's higher prevalence of individuals with psychiatric disorders to start out with another type of proactive model?
Yeah. So we've actually, and this is related to perinatal mental health, just because that's where I practice, but we've been talking about doing this in the NICUs across our system, just because we know that that is a particularly vulnerable group, and we do have a child psychiatrist on our service, Meredith Spada, if any of you have met her, but she is she's child trained, interested in infant mental health, and works on our consult service. So, you know, we have the ability to do this, and a lot of interest across multiple hospitals for something like this. So that's one population. We're actually looking outside of peripartum health, because I know not everyone is super into pregnancy and postpartum care. We're thinking about, we have partnerships with trauma surgery, looking at our gun violence population. This is in person. But also our post-cardiac arrest patients as well. We're trying to be a little bit more proactive with that particular patient population. And we're in earlier stages in terms of kind of figuring out what the needs are particular to those populations. But those are the areas that come to mind in terms of what we're doing right now.
How does a psychiatrist do in telepsychiatry talk to the nursing staff, talk to other staff members who might be present, see the patient? How does that all get done?
Yeah, well, I mean, we do it all through tele for the most part. So I've actually never been to Horizon or Northwest. I have been to Jameson. So we, you know, we get ourselves, you know, it's consultation liaison. It's a lot of liaison work, right? So we get ourselves onto lunch and learn sessions. We get ourselves onto grand rounds. We like meet one-on-one with people. But I think the important part to know is that we have a clinician on the ground at these sites. We kind of insist on that, and the hospital pays for that. So that helps in terms of creating relationships, but it also helps in terms of making sure that we mimic the workflow that we have at our primary in-person site. So after we see the consult, the clinician actually takes us to the primary team, and we give recs sort of face-to-face through the video. So that has helped quite a bit. And during COVID, actually, all of these women that we're screening at Northwest, we're actually connecting to our Mickey behavioral program in Pittsburgh, which is, you know, Western Psych run. So we've been able to do virtual like linkage to outpatient care, and they've been much more, that community has been much more open to seeing like a Pittsburgh program than our other one has. So it's been kind of an interesting exercise, and we're hoping that it continues. Although, you know, who knows what's going to happen with that, but that's our hope.
All right, great. Well, we're just at 1 o'clock, and very interesting to learn about. I thank you, Dr. Gopalan, for presenting this work, synthesizing things in the literature and from the services that you've developed and oversee, and really appreciate it. And thank you again for presenting today.
Thank you so much for having me. I appreciate it. Thanks
okay.
for your time.
And we'll end there. Well, thank you.
Bye.